Guess I can get started, everyone. Welcome, everyone, to today's medical grand rounds here at St. Joe's. I'm stepping in for Dr. Verhofsek. She's away this week. I'm Jason Chung, head of service for general internal medicine. And it brings me great pleasure to introduce you all to Gousia Dhhar, who's one of our new clinical pharmacology recruits, who will be presenting to you guys on a topic of salicylate toxicity. And to introduce all of you to Dr. Dhhar, I have with us Dr. Ann Holbrook, who I believe requires little introduction. She has been around, a very senior faculty member who's been with us for a long time now as the division director for the Division of Clinical Pharmacology, as well as the head of service for the Clinical Pharmacology Service. And I'll leave it to Ann.
Thank you, Jason, and welcome everybody to Grand Rounds. Really gives me a lot of pleasure to introduce Gousia. I'll just paint you a bit of background. Clinical pharmacology, you may or may not know, has 4 active clinical members right now. The smallest division has been the smallest for a long time. So recruiting Gousia has been probably the major achievement of my career in this area. So it is wonderful to have a fully trained Royal College certified clinical pharmacologist with us. So Gousia started on faculty in July, but a number of you would have worked with her over the probably year or two before, perhaps when she was a clinical scholar. She's taken a very kind of long and probably varied road, maybe as a lot of us have, to her current position, started as an IMG. Very well trained at the University of Toronto in both internal medicine and clinical pharmacology, completing a master's in education. Actually, Gousia, you could tell us what stage you're at, contemplating a PhD. So a very well trained clinician educator, and we have very high hopes. I think clinical pharmacology education for our trainees will definitely advance under Gousia's role with us here at McMaster. And without further ado, Gousia, do you want to go ahead and start your talk?
Thanks very much, Dr. Chung and Dr. Holbrook, for the very warm introduction. I'm sorry, the teams being teams and technology being technology, I was having some trouble. You probably can't see me, but you will find me on the wards. And I was also having some trouble with the slide, putting it in the presenters mode. So, but we'll work with what we have and we'll get started despite a little bump. So first, some slides about St. Joe's. I was asked to put this at the beginning of my presentation, and I'm very proud to do that, very proud to be a part of the St. Joe's part of St. Joe's community, and also being a part of clinical pharmacology and toxicology and both GIM. So a slide about land acknowledgement. I'll give you a moment all to read this slide, acknowledging that this is not an end of any conversation, but beginning of many conversations that should and must happen. Okay, I'll move on. So I have no conflicts of interest to declare, and today we'll be talking about salicylate toxicity. The objectives of this talk are to talk about acute salicylate toxicity, its presentation and management, and also in many ways to contrast it with how chronic salicylate toxicity presents, especially in elderly, and how to manage that. So there are different sources of salicylates that can lead to toxicity. As you know, the most common prototype is aspirin. Then there are other sources that have been well described to cause toxicity, including oil of wintergreen. This is a derivative from a plant and contains methyl salicylate, and then pink bismuth or pink lady. And as talked about, as I just mentioned, that aspirin is the prototype. It's actually the acetyl salicylate. I've tried my best to keep the core pharmacology out of this. I don't want to put you to sleep. And the source of salicylate, this one, oil of wintergreen, it is methyl salicylate. and commonly found in these medications that are applied for pain control, for topical pain control. So you can see how concentrated this is, with 1 ml containing 1.4 gram of aspirin equivalent. So you can imagine if this is taken accidentally, how much toxicity it can result, considering that 1 tablet of aspirin, a regular aspirin tablet, is 81 milligrams. And then other sources of salicylates is bismuth subsalicylate. And to give you an idea how much this contains, it's 15 mils. Contains in the regular bismuth subsalicylate, it contains 130 milliequivalents of aspirin equivalent. And in the ultra, or the more concentrated one, it contains almost double, to 30 milligrams of aspirin equivalent. And there is also a warning with this that probably many people don't read, which is about not to take this with other aspirin or salicylates, and also to keep it away from children. So these are the sources we talked about, but we probably all of us at some point have seen a patient with aspirin toxicity or salicylate toxicity. But the question is whether these can cause significant toxicity. And yes, they do. They can cause both chronic toxicity and also acute, that I'll mention. The chronic part we'll talk about more so in its presentation in elderly, and we'll talk about the acute one too. So methyl salicylate toxicity, it can happen with oral consumption as well as with skin absorption. And to skin absorption, it depends on the dose. That means the concentration of the cream that is applied, the frequency of application, what age group this is being applied, and also the surface area. There are various case reports of toxicity where just applying a 25 to 50% cream to a scalp in a 2-month-old baby led to irritation, tachypnea, seizures, and presentation to the emergency department. And there are also multiple case reports where skin application of methyl salicylates can lead to salicylate toxicity. There is a case report that is described with methyl salicylate and oil of wintergreen in an elderly gentleman where he had a helper who would apply this every single day to his knees and to his legs, and one day left the bottle open by his bedside. The elderly gentleman, thinking that this is probably his usual medications, took a quick sip of it, although he vomited it right away. But after around 20 minutes, he was found seizing. He was taken to the hospital, and he was and presented with a classical toxidrome of salicylate poisoning, and was started on dialysis. But despite dialysis, his levels kept going up, and the reason was because the helper had been applying this on his legs, methyl salicylate on his legs. So he was having ongoing dermal absorption despite dialysis, and eventually died. And this is just to emphasize that when we think about methyl salicylates and the ointments or creams, it is not benign. And then there has been an interesting case in a case report in a teenager where he applied methyl salicylate for pleasure to the genitalia, and overnight seemed to be okay, but in the morning ended up in the hospital with salicylate toxicity. Then coming to the mechanism of action for aspirin, we all know that it's a non-selective COX-1 and COX-2 inhibitor. COX-1 has an antiplatelet effect. COX-2 is the anti-inflammatory effect. So let's look at the salicylate kinetics. The half-life typically is 2 to 4 hours, and peak concentration can be achieved just in an hour. And for delayed release, this is 4 to 6 hours. Now, contrasting this with the toxic doses, as you can see, the same math doesn't apply in the toxic doses. The toxic half-life is 20 hours. The peak concentration is prolonged by many hours, and the delayed release can, the peak concentration can be further delayed. And it's important to know this, because when we think about toxins or toxicity, we quickly try and look up the half-life to see, okay, what do I expect in my patient? But remember that the toxicokinetics are different than the therapeutic kinetics. And part of the reason why this happens, particularly in salicylates, is because as the concentration goes up, and typically it has been seen that when there is a concentration of 360 milligrams of aspirin in the body, then at that point there is a change from first order elimination to zero order elimination. What it means is that instead of the same proportion of drug, there is a constant amount of drug that is being eliminated, and hence you can see in here that there is a further delay in clearance or elimination of the drug. Then salicylates are also known to form bezoars, and this is a picture of a patient with around 300 tablets of aspirin in bezoars. How bezoars present is that once the salicylate level starts to going down, there's intermittently starts going back up again. So something to be mindful if our patients are on treatment, but their levels keep going up and down, something to be mindful. And then again, aspirin also causes pylorospasm, which can further delay the absorption and the toxicokinetics. So salicylate metabolism, quickly speaking. So first we'll talk about in therapeutic dosing. So acetyl salicylate, this is talking about the prototype aspirin. It gets quickly converted into salicylic acid by hydrolysis in the gastrointestinal tract. Now, 90% of aspirin is protein bound with some free available salicylic acid. Now, this is metabolized in the liver through phase 2 metabolism, no CYP enzymes involved here, and the rest of it is, most of it is metabolized in the liver, the rest gets filtered in the kidney. Now, let's see what happens in toxicity and how this changes. So there's a lot more free salicylate available. The liver saturates, the liver metabolism gets saturated, and a lot of free salicylic acid is available in the kidney, in the tubules. Now, there is a significant effect of pH and distribution of salicylic acid. So in acidosis, salicylic acid, it remains in the non-ionic form, and as you can guess from this, it's the bad guy. It's the non-ionic form that we don't want it to be in. And then with alkalosis, it stays in the ionic form. And why one is good and why one is bad is because the non-ionic form is the form that enters the organs, including brain, and causes end organ damage. While the ionic form, it stays within the blood vessels. This is the effect of pH on distribution. And you can imagine that if the pH, how much of this, how sensitive it is, that if the pH falls from 7.4 to 7.2, it essentially leads to doubling of concentration in tissues. Now, this is important when if our patient, typically we avoid intubating patients with salicylate toxicity. But if it is needed and they need to be intubated, that period of apnea can quickly drop the patient. So it is to be mindful that while we're taking care of the airway, it's quite possible that we may be actually precipitating organ toxicity. And that is the point when we would push for more bicarb. And I'll talk about that later. So there is also effect of pH in tubules. And in acidic urine, again, the salicylated remains in the non-ionic form, and in alkalotic urine, it remains in the ionic form. Now, imagine that these are the peritubular capillaries and tubules with interstitial space in between. So what happens in acidic urine is a lot of this salicylic acid moves from the tubules into the peritubular capillaries, and then eventually goes into the tissues or the organs. And in the ionic form, in alkalotic urine, it stays within the tubules and is eventually excreted. And again, there is a significant effect of pH. An increase in pH from 5 to 8 within the tubules or urinary pH, it can increase the tubular concentration of the ionic form from 3% to around 80% and aid in elimination. There are also various acid-base disturbances classically that we know of in salicylate toxicity that to be able to recognize this toxicity. So it leads to respiratory alkalosis, as we know, and there is both stimulation of central and peripheral respiratory centers. There is also anion gap metabolic acidosis due to various reasons, which is there is uncoupling of the oxidative phosphorylation in mitochondria. There is also inhibition of the citric acid cycle, more glycolysis, more lactate production, more keto acid production, inefficient energy production. There is less ATP production, more heat production that leads to hyperthermia and rhabdo in patients. Then there are other acid-base disturbances, including the non-anion gap metabolic acidosis. And the reasons why this happens is there is excretion of bicarb and chloride retention to compensate for the respiratory alkalosis. Also, salicylate triggers the chemo trigger zone, leading to nausea, vomiting, contraction, alkalosis. Now, in addition to these acid-base disturbances, there are other features in salicylate toxicity that we need to be mindful of. Initially, there can be transient hyperglycemia, and the transient hyperglycemia can occur because there is breakdown of glycogen and also inability of the tissues to utilize this glucose. But after this, there can be pretty profound hypoglycemia, and that is due to depletion of glycogen stores. What is important to note that there is neuroglycopenia. That means even if the serum levels are normal, patients with salicylate toxicity can have, various studies have shown that even up to 30% lower levels in brain and CSF. The exact cause is not known, but it is believed to be related to the effect on glucose metabolism and its utilization by the tissues, as well as transport. So let's talk a bit about the acute salicylate toxicity. So typically, usually young patients, occasionally can be elderly too. And there's a clear history of overdose and possibly some psychiatric history as well. Now, the toxic dose, all of this can be looked up, but in general, anything more than 6.5 grams, we start to worry about. Then there is moderate, severe, and lethal dosing, and this can be weight-based. So clinical presentation, again, can be mild, moderate, and severe. So in mild, mostly GI symptoms, and it's important to ask about, even for mild symptoms, to ask about hearing loss, tinnitus, and dizziness. The moderate ones we see more so when the changes in acid-base are seen in moderate toxicity, where patients can have tachypnea leading to respiratory alkalosis. They can develop hyperpyrexia and metabolic acidosis, as well as dehydration. The severe toxicity is end organ damage with CNS involvement, can present as seizures, stupor, even hallucinations. There can be cerebral hemorrhage, involvement of cardiorespiratory symptoms with the pulmonary edema, and also renal involvement, and eventually death. Now, typical investigations, there's a lot of investigations. As soon as the patient walks in the emergency room, we throw in a whole bunch of investigations as a routine, but particularly be mindful about blood gas, plasma glucose, lactate, ketones, and urinary pH. And as I mentioned before, that plasma glucose, even if it is normal, but you're worried about decreased level of consciousness, please go ahead with giving the patient extra glucose in the form of D50 because of neuroglycopenia. And then also consider serum salicylate concentrations and the usual tox workup with acetaminophen and toxic alcohols too. Treatment, consider decontamination. This is more so important when patients present early, typically within 2 hours. We can consider activated charcoal, but be mindful of the adverse effects and contraindications to activated charcoal, including if the patient is vomiting, they have decreased level of consciousness, then we would have to avoid this, or they have small bowel obstruction or are having seizures. because there is pylorospasm, and certain studies have shown that aspirin can still remain in the stomach for longer. So it's quite possible, especially in delayed release salicylate toxicity or delayed release aspirin toxicity, to give activated charcoal outside of this window too, maximum up to 4 to 6 hours, but not after that. There's also a role of activated charcoal late into toxicity if bezoars are being formed. Whole bowel irrigation is done again when in presence of bezoars. Elimination, it's the main treatment method. With urinary alkalization, as mentioned before, it converts salicylate into its ionized state, which increases elimination. We typically target a urinary pH of more than 7.5 and can start urine alkalization when the salicylate levels are more than 3.5 in an acute overdose. This is quite variable in terms of when we talk about chronic overdose. And then there is no role of oral bicarbonate, because it is shown that oral bicarbonate can actually worsen toxicity by increasing absorption. And there are certain indications for dialysis too that we'll talk about in some time. While the patients are being treated, it's important to monitor them every 2 hours. This is what the Poison Control, Ontario Poison Control recommends, and this is for more sicker patients. If your patient is more stable, this can be 2 to 4 hours. So every 2 hours, urinary pH with a target of more than 7.5. Serum blood gases and a serum pH target, we typically target less than 7.56, and we avoid a further increase in pH. And then serum potassium, we target a normal serum potassium, and of course, we follow the serum salicylate levels. Endpoint of alkalization, when aspirin levels are less than 2.2 millimoles per liter, and there are 2 consecutive aspirin levels, they're still coming down, and the patient is clinically well. There are some contraindications to urine alkalization, and which is end organ damage. If the patient presents an end organ damage, we can always start it until dialysis is set up. But if somebody is already in pulmonary edema, then this may not be the first thing to start, or in severe renal failure, then dialysis would be the next step. It's important to know the supportive measures along with all of that all of the things that I mentioned before. So fluid resuscitation, these are severely volume deplete because of third space loss and hyperthermia. Cooling should be initiated if they are hyperthermic, including active cooling. If there are seizures, the benzos should be the first line of treatment. And as I mentioned before, that it's common to under-recognize neuroglycopenia. So I have a low threshold to give start dextrose in someone, even if who has normal serum glucose levels. And then we talked about dialysis, and so XTRIP, it is an evidence-based guidelines for toxins and dialysis and toxins. They recommend starting dialysis at certain concentrations more than 7.2 or at more than 6.5 in presence of renal failure. And also other end organ damage dialysis indicated, including altered mental status and hypoxemia and failure of supportive measures. Yeah. So there are certain challenges that when working in the Poison Center, we would get called from the hospitals that the patient is clinically doing well, but the pH is less than 7.5. We have not been able to target a pH of 7.5. So the normal response is, okay, let's just crank up the bicarb and see what happens. But before we do that, think about where you're getting your urine from. If it is from a Eurobag, it may not be the new urine or may not reflect the recent urine pH. So Eurobag should ideally be emptied before taking a new sample. Now, the other scenario that we get called is patient is clinically unwell and the urine pH is less than 7.5. They've been cranking up the bicarb rate, but it has not really helped. So before you do that, think about hypokalemia. Because with hypokalemia, what happens is that body tries to secrete the proton in exchange of potassium. It tries to hold on to the potassium. And no matter how much we go up on bicarb, if there's hypokalemia, we can't really truly make the urine alkalotic. So some scenarios to consider. So this is about acute toxicity and chronic salicylate toxicity. This presents in a different way, usually in different patient population. So chronic toxicity, usually these are elderly patients. They have no history of overdose. They have, their salicylate levels may be high normal. That means the normal is 2.2 and less millimoles per liter. Their levels may be 2.4, 2.8, but not toxic. And it's important to know that the plasma levels do not correlate with the clinical manifestations. It's important to take drug history, and drug history for both topical application, for all topical applications, herbs, any additives, ginger, mint teas, essentially detailed drug history. So chronic salicylate toxicity, and it applies to a lot of our patient populations, it is challenging to diagnose, and they typically present an unexplained decrease in capacity for self-care. I'm just going to give you all a moment to think about that. What were the initial diagnoses that were made for patients who presented with chronic salicylate toxicity? And this is when they presented to the emergency department or they presented to the clinics. And what were the initial diagnoses given to these patients? So NEJM reported that many of these patients were given a diagnosis of encephalopathy of undetermined origin, dementia or delirium, viral encephalitis, and even stroke, because occasionally they can present with focal neurodeficit. Because they present very subtly in a subtle way, in inability to care for themselves, sort of decline, sometimes hallucinations, confusion. So they were given these, they're given these diagnoses. And there is a case report where a female, a 70-year-old female, who was had a previous history of stroke, no deficits from that, was on aspirin, and was taking her aspirin at a higher dose than what was recommended for her. She was taking 2 tablets of 325 milligram every day, and in addition to that, had some joint pain, and then purchased methyl salicylate and started applying that to her body. She presented to the emergency department with a right-sided deficit. Her previous deficit in stroke was on the left side. So she presented with right-sided weakness. A CT was done for her, an MRI was done for her, and all of that was negative. And then eventually, blood gas was done, showed respiratory alkalosis, and then further history brought to light that she had been taking way too much of aspirin. She was started on urine alkalization, brought down her levels, and she returned back to baseline. These patients are also initially diagnosed as having a cardiorespiratory disease, and that is related to sometimes they can have unexplained asterixis and the increased respiratory rate. So they can be diagnosed with various cardiorespiratory illnesses. They sometimes also get the diagnosis or misdiagnosis of alcohol intoxication, alcohol withdrawal, and alcoholic ketoacidosis. There is a term that we use. It's called salicylate JAG. It is jitteriness, fidgetiness, confusion, and it mimics the alcohol intoxication and withdrawal. The patients were also, because of hyperthermia, sometimes they can present with hyperthermia. They have been misdiagnosed as sepsis, and occasionally diabetic ketoacidosis for starvation ketosis. So chronic salicylate toxicity diagnosis, again, as I said, it is extremely challenging to diagnose. There has to be a high level of suspicion. If the patient is presenting with tachypnea, they're presenting with acid-base disturbances, especially respiratory alkalosis, and they're presenting with focal or non-focal neurological findings that we don't have a good explanation for, and deterioration in ADLs. One should have a high suspicion of this. There is a case report that mentions an 80-year-old male, I believe, who presented to the emergency department again with failure to cope. And a full DIMS workup didn't reveal anything. And then he was noted to have respiratory alkalosis, and further history reveals that he had been taking the Pink Lady or bismuth subsalicylate around 2 bottles every day for GERD. Little knowing that this was the cause of his symptoms. So he was his bismuth subsalicylate was, of course, discontinued in the hospital. He was started on IV fluids. His level was, I believe, 2.4. So again, as I said, the level doesn't really correlate with these symptoms. And eventually his level came down to less than 1, and he did fine and was discharged home. So I can't emphasize enough drug history in all our patients. And I'm not just saying this because I'm a clinical pharmacologist, but this is really important to get the drug history to be able to both diagnose and manage your patients. And then treatment. Most important thing is to be aware, as I just mentioned, that the symptoms and signs don't always correlate with the levels in chronic toxicity, and to stop the exposure and consider alkalization if the levels are more than 2.9 millimoles, and target a level where there's symptoms to try and see if their symptoms improve. So these are the references that I used. And again, as a recap of acute salicylate toxicity and management, be aware of how mild, moderate, and severe toxicity presents. Be mindful of neuroglycopenia. Be mindful that intubation can actually lead to worsening of organ damage, and urine alkalization. Think about supportive measures, and chronic toxicity, how to diagnose and how variedly it can present in elderly. I think we are well ahead of time, and I'm happy to take any questions and comments.
Thank you very much, Gousia, for the lovely talk. It was a great overview of a topic that, as far as overdoses, at least from this time on service that I've been on, we don't tend to see too much aspirin toxicity, I find, but it's always great to review this topic, and a lot of great clinical pearls around both acute and chronic toxicity. So thank you very much. We have a question from Mitch.
Go ahead, Mitch. It looks like you're unmuted.
Now I'm unmuted. Okay, it took a while. My thought was this neuroglycopenia. I was always under the impression that actually wasn't the big problem, but the reality was that it was the glucose in the CSF cannot be used by the neurons because of the salicylate toxicity on the neurons, and that's why the neurons die, because they need glucose. And it's just they're not able to use it, as opposed to that there's a deficiency of glucose in the CSF.
Thanks for the comment, Mitch. So there have been, as I said before, that we're not entirely sure why that happens, and that was the initial thought, that perhaps the neurons are not able to use the glucose because of. Sorry, is there an echo?
It's okay.
Okay. So they weren't able to use, but when they conducted studies, they actually did see that the CSF levels of glucose in toxicity were actually 30% lower than the serum levels. So which means that it is not only a problem of usage, but also glucose transportation or glucose, and as you said, glucose utilization. So that is why if it is recommended that, especially even with normal glucose levels, if you do see that the patient is getting confused or they have decreased level of consciousness, be mindful of the phenomena of neuroglycopenia, even which means that they could be having low levels, and to give in a D50. This would be different in somebody's really hyperglycemic, because you don't want to create further problems for them what's going on. But typically it is highly recommended, and it has been looked into where they did see that the levels were lower than their.
Yeah. Okay, thanks.
Jason, maybe while people are thinking of questions, Gousia, I can just add a little bit of historical context and plug. So when I started in practice, there wouldn't be a week go by that we wouldn't see a couple of salicylate toxicities. And as you mentioned, we weren't so good at recognizing chronic, but there was plenty of acute then. So it was a more common overdose than what we see now. But I think the reason of emphasizing, you did an excellent summary, is that I don't know that physicians really appreciate how easy it is for patients to get anything at all on anybody's market or not on anybody's market. So I actually have a little practice oral with the seniors around topical salicylate, because nobody seems to realize that A535 rub, which has got a very prominent part when you go and do your pharmacy safari, is 30% methyl salicylate. So well-known cause of potential toxicity. You can get wintergreen again. That had gone off the market decades ago. In my grandfather's era, it was a common painkiller, not now. But you can get these things from anywhere. We're not really supposed to have access to extra strength aspirin. We have 325. But again, you can buy it online. So as you're emphasizing, Gousia, I think the history of what people have been into, not just what they're prescribed or, classic over the counter, is really important.
Thanks for the comment. And yes, that's very true. There is so much that's available on the internet. You can get all of wintergreen from Amazon. And even the methyl salicylates, there are different concentrations. So there can be anything from 20% to 50%, which is, I actually don't know if the 50% is available online, but occasionally there have been case reports where things like these have been recommended by I should say pseudo doctors who set up their clinic without any knowledge about this. And this is more so in the not in the West, more so in the East and other countries, where they have actually prescribed patients methyl salicylates for various skin diseases. So, and this has resulted in very severe toxicities.
We have an interesting question from, I presuming the residents who are studying for the Royal College exam here. It's in the chat here. I'll read it out. So, a patient with suspected drug overdose with TCA and aspirin. What would be the most likely finding with this overdose? A, pulmonary edema, or B, metabolic and respiratory acidosis?
Okay, that does sound like a very Royal College question. So with a TCA overdose and an aspirin overdose, and what are the options here? Pulmonary edema and?
Or metabolic and respiratory acidosis. What would be the most likely finding?
So, well, thank you for the question. But if I had to choose, so both could happen, right? But if you think about what does TCA do? TCAs also have pretty strong antihistamine effects that causes decrease in level of consciousness. And if you have a significant TCA overdose with decreased level of consciousness, that might actually overcome the respiratory alkalosis. So if I had to choose, I would actually do metabolic acidosis and respiratory acidosis.
Maybe I could pose a question as well, Gousia, while we're waiting for anyone in the audience to think of any other things to ask. But so would you say in your practice, given especially the bit about the chronic salicylate toxicity in our generally fairly elderly population that we see on internal medicine, many people are still on aspirin for a variety of reasons, whether appropriate or not, primary, secondary prevention. Do you routinely send off levels to check when you don't have a very clear history around the cause of their presentation with acute confusion or that sort of encephalitis delirium picture? Is that something that you do in your practice?
So thanks for that great question. You know, in the world of choosing wisely, and also what is known to me, I do try and first take a drug history, a very thorough drug history, which means that speaking with the patient, with their confused family members, taking help from pharmacy. But in all honesty, if I don't have a good reason of their presentation and I'm not able to take a good history, then that is what I would do. But before doing that, I typically do ask for a venous gas. If there are concerns of respiratory alkalosis, then I do ask for a salicylate level.
Thanks so much.
And because we were talking about respiratory acidosis and we were talking about metabolic alkalosis, and we do have some time, I do want to say that occasionally there have been actually case reports about it that aspirin or salicylate toxicity can present as non-anion gap metabolic acidosis. And part of the reason is because the salicylate assay interferes with chloride assay. So your chloride can actually be falsely elevated, and and these patients can have non-anion gap metabolic acidosis. So be mindful of that. If you're quite suspicious that this could be aspirin toxicity or salicylate toxicity, but your anion gap is not elevated, I would still keep it in the differential. Perhaps give a call to the lab and say, hey, do you think that this could be related to the high aspirin levels? Still treat them.
We have a fairly quiet crowd today in terms of questions. So I'll take this opportunity to again thank Gousia for a great talk, and wish everyone a happy holidays over the end of December and into the new year. And I think things get started up again sometime in January, and Madeline should be back to host again. So thanks very much, everyone.
Thank you very much for the opportunity. Thanks for the questions. Right.